from Case Western Reserve University, my alma mater, with her Master's of Science in Nursing in 2014 and obtained her FMP certification in early 2015. All of her nursing experience is in oncology. She worked as a nurse practitioner at MetroHealth Medical Center Breast Clinic since 2015. She is passionate about taking care of women and men that are at high risk for breast cancer and helping them live their healthiest life by high risk screening, preventative measures, and educating and motivating them to make healthy lifestyle changes. Anna is a board member of Feeding Souls Ministry and volunteers weekly with this organization at St. Malachi Church in Cleveland, Ohio. Welcome, Anna, and thank you for joining us and presenting today.
Thank you for having me. It's a pleasure. Well, should I just go ahead and get started?
Is there anything you want to tell us about yourself that we didn't mention?
No. No.
You can share if you want to. Feel free. I did meet little Anna, Clover, your daughter. She is so beautiful.
Oh, thank you. Yeah, little Anna, she does. I get a lot of people tell me we look alike.
When she introduced you as alma mater to Case, yes, Case is a great school.
Yeah. Although I'm sure we'd all be living in a little bit nicer houses or driving a little bit nicer cars if we didn't go there, though. Paying down these loans. That's a serious endeavor.
I go to Case, oh wow. But
all right, well, we're glad that you're here to talk to us about breast cancer workups and treatment. So please enlighten us. Tell us more about, what you do and how we can help and, all the good stuff.
Okay. Yeah, so as Lavada said, I'm a nurse practitioner and I work in the breast clinic at MetroHealth. And I really do love my job so much. And so I see a lot of women that have benign breast problems, like maybe breast cysts, abscess, breast pain, fibroadenomas, those kinds of things. And then I also see a lot of women that are very high risk for breast cancer, or they have gene mutations that put them at high risk. And then a lot of women that are just coming in because they have an abnormal mammogram and they need a biopsy. And I kind of sort of help them through that workup and help them through the diagnosis if the biopsy comes back positive for cancer. And then I work mostly on the surgery side of the breast cancer treatment. But today I'm going to kind of give a broad overview of all the elements of treatment too. And I think Lavada went in a little bit into some of the statistics, so I hope I don't bore you as I start off with a few here at the beginning. So, and maybe most of you know, but breast cancer is, in 2019, it was the highest number of cancer diagnoses in America for women was breast cancer, followed by lung cancer, which is almost double the amount, or more than double the amount actually of lung cancer cases, which was the closest second. And then for men, prostate cancer. However, though, as far as number of deaths from breast cancer, it's second in number of cases after lung cancer. So it affects a lot of women. But not all of them die from breast cancer. In fact, most do really well, and most women are survivors. So it's really good news. So I kind of went over this. The number that we throw out there for cancers affecting women is this number 1 in 8 for breast cancer. And in lung cancer, it's 1 in 16. In colon cancer for women, it's 1 in 19. So that kind of just gives you, an overall picture for endometrial cancer, which is also referred to as uterine cancer. It's 1 in 41. So it's just another way of kind of getting an overview of how much more commonly breast cancer is diagnosed in women. One thing I do want to point out, however, with that 1 in 8 number that I was looking at the statistics about it, there's actually a little further breakdown. So it's 1 in 8 women if you live to the age of 80. But if you're in your 20s, the number is more like 1 woman in her 20, in the whole decade of your 20s in 1,567. So it's not common in your 20s. The number that it is in your 30s, it's 1 in 220 women are diagnosed with breast cancer in the decade of your 30s. And the number kind of like slowly gets cut in half, and cut in half until you get to 80 in your 80s. And then it's 1 in 8. So just to break it down a little bit more, it's not just like the whole slice of life, but if you make it to your 80th decade, then the number is 1 in 8. So that kind of brings out the point that young women, it's much rarer in your 20s to be diagnosed with breast cancer than it is in a woman who's in their 80s. Let me go back here a few slides. Okay. So we kind of went into this second leading cause, 1 in 8, about 12% is kind of the average number we give people when we're talking about averages, lifetime risk for breast cancer. And then you saw that on the first slide, about 250,000 women a year are newly diagnosed, and about 40,000 cases, there's 40,000 deaths from the disease per year. And with breast cancer, of all the cancers, I used to work as an oncology nurse and work with all different types of cancer, and breast cancer is the outcomes are so good with breast cancer and diagnoses that I do, it's, so we've got some good news, and I think that there's been a lot of very focused and targeted treatments and a ton of research that's gone into the treatment, the treatment of breast cancer that's made this sort of more, remarkable evolution in the treatment over the last 50 years. So we think that it has a little bit to do with like increased awareness and all the screenings and early detection, better surgeries, more targeted chemotherapies, immunotherapies, and radiation therapy. And so we'll get into that in a little bit as well. Here's just some more, kind of updated or statistics just regarding race and incidence of breast cancer. So you can see that white women have a higher incidence of breast cancer on this graph, but as far as mortality goes, which means death from breast cancer, more Black women die from breast cancer than white women. And this graph kind of shows it up to 2008, but unfortunately this trend is still the same, quite similar. So it still kind of follows that line. Just to hang on this point for just a lot of people ask me when I give this presentation, why is that the case, and why does that seem to continue? And it seems that the disease is a little more aggressive in African American women at younger ages, and at that time when the screenings are not being done, and say in a 30-year-old, we don't start screening. And so that may be, maybe an element of it. May also have to do with access to care. Yeah. But there's a lot more research and that needs to be done to kind of work on those numbers. Here's another chart that kind of shows that in a different way, showing that like non-Hispanic white women, there's much higher cases of that, but as far as mortality goes, the numbers kind of flip. And you can see that also with Asians and Native Americans, and then Hispanic, Latino. So that kind of gives you the, in order where non-Hispanic whites have the highest incidence, then non-Hispanic Blacks, Asians, then American Indians and Alaska Natives, and then Hispanic Latino, sort of the numbers for incidences. So just quickly, what is breast cancer? It's a malignant tumor that starts in the cells of the breast. So a malignant tumor is a group of cells that can grow in an unregulated fashion into surrounding tissue and spread to distant, potentially spread to distant areas of the body. It almost always occurs in women, but it also can occur in men about 1% of the time. Typically, if it does occur in men, there's usually a really, quite a strong family history sort of associated with that. Another nice little picture, I don't know if you guys can see this well, but it's sort of some breast anatomy. You've got mostly fat in your breasts. You've got these ducts, they're little tubes that take the milk to the nipple when you're breastfeeding, and then lobules or milk glands that fill up with milk when you're breastfeeding. A lot of times we find the breast cancer cells are either ductal or lobular, and it's sort of related to the origin of these cells that are in your breast tissue. So a lot of times you'll hear those terms, ductal carcinoma or lobular carcinoma. So sometimes people ask, like, what are the symptoms? Like, or a lot of times people don't have any symptoms when it's an earlier finding. And so maybe a lot of times breast cancer is found on a mammogram and a woman did not have a palpable mass. They had no skin changes, no redness, no changes that are obvious in their breasts, and they'll come in for an exam and I can't feel anything. But it's just been found on a mammogram. And our mammography is catching the tiniest little masses. And so a lot of times there are no symptoms until things get more advanced, where you may then have a palpable mass. You may have some skin changes like redness or peeling around your nipple, or either like a change in the contour of your breast or nipple discharge. And then symptoms that can be more in your body or more systemic are like weight loss or bone pain, changes in your bowel habits, cough, headaches. You just have to be really careful, because a lot of these things you can have and are completely not associated with breast cancer. So but sometimes we'll find that in some of the later stages that some of these symptoms can be present. Risk factors. So the number one risk factor for breast cancer is being a woman and then getting older. And I think you've probably seen that as I sort of presented earlier, and really in your 20s, your risk for breast cancer is extremely low as compared to, when you're in your 80s. So in each decade of life, your risk for breast cancer increases. Having your menstrual cycle at an early age, like 9, 8 or 9, something like that, and then a later menopause, like later in your 50s. So you've got that exposure to your own body's hormones for a lot longer time frame. Having no children, which kind of can give you a pause or a break, or having your first child after the age of 30. Gaining weight, obesity, the belly fat. So the fat cells that hang out around your belly, those store estrogen, and that is like another source of estrogen that can put you at higher risk for breast cancer. Lack of exercise, alcohol, with alcohol, it's more than one alcoholic beverage a day, sort of what the kind of the research shows. So a significant amount of alcohol. Who is at risk? So who is at risk for breast cancer? Women that have a prior history of breast cancer, women that have dense breast tissue, women that have 2 or more relatives with breast cancer on one side of the family, or one family member with ovarian cancer, or personal history of ovarian cancer, close male relative with breast cancer. Some of the more benign proliferative diseases like the atypias, like atypical ductal hyperplasia or atypical lobular hyperplasia, which are these usually found on mammography and through biopsy. They're not cancer, but they're high risk cells, and typically, surgery is recommended, and extra screening going forward is recommended for women with those pathologies. And then the BRCA1 and 2 gene mutations. And I wanted to just go over that. If you have a BRCA1 gene mutation, your lifetime risk for breast cancer is 87%. It's really high. And it's 45% for ovarian cancer if you're BRCA1 positive. If you're BRCA2 positive, your lifetime risk for breast cancer is 85%, and your lifetime risk for ovarian cancer is 27%. The BRCA2 also, gene mutation also carries along with it a little bit of an elevated risk for melanoma as well. And so those women, we screen them frequently. If you're BRCA1 positive or BRCA2 positive, but if you have your ovaries removed, that can cut your lifetime risk for breast cancer by 50%. And so sometimes women will do that and they'll still be screened until, and sometimes women, opt for prophylactic surgeries, something as well. Also, a previous history of radiation to the chest. So there's like this type of radiation that's given to women and men that have been diagnosed with lymphoma, non-Hodgkin's lymphoma, in their early 20s. And teens, it's a sort of a more common type of lymphoma for younger people. And one of the treatments is this chest radiation. And it's effective for the lymphoma, but it does then put you at much higher risk for breast cancer than about a decade later. And so we start also screen those people with a lot of high risk screening and just watching them very carefully. And then also long-term use of hormone replacement therapy, which has sparked a bit of a debate, but the continued research is leaning towards that being a concern. So hormone replacement therapy is given to women that are going through menopause, and to help treat some of those symptoms like vaginal dryness, the mood swings, the hot flashes, especially the hot flashes and the vaginal dryness. So if you're taking that for 7 or more years, is about the time where you should consider to stop taking that, because your risk, you can kind of boost up your risk for breast cancer. Okay. A few other things here. There's certain things you can't change, like I was talking about. You can't exactly impact when you get your first period. You can't change your family history. You can't change your race, your ethnicity. You can't change the anatomy of your breast tissue, like the dense breast tissue. But there are lots of things that you can change that can help reduce your risk for breast cancer, like diet, getting enough sleep. That's a really important thing. The melatonin that your body produces is an important hormone in preventing cancers, and just watching how long you're on the hormone replacement therapy, reducing alcohol, exercise, those kinds of things. Trying to have your first baby before you're 30. I don't know if you can, I don't know. Some people can change that. So that's something to consider too. So although, you know, you can make all of those, you can live an extremely healthy life and never smoke, never drink, have no family history, exercise and eat healthy, you can still develop breast cancer. And so it's important to note that breast cancer cannot be prevented, but you can do things to kind of help you decrease your risk. And also getting screenings it can make a significant difference in your outcome. And as you can see on the next slide is a little bit light, so I hope you guys can see it. But you know, your 5-year survival rate for someone who's got a stage 1 breast cancer is 92%. So stage 1, we can classify that as basically a breast cancer mass that's under 2 centimeters. And that's about there's a few other factors that go into it, but I'm just going to kind of weigh in on basically the size. So the size of the breast cancer mass that's found in your breast is important because it does play a role in your survival, which means getting your screening so that that breast cancer is found at an early stage is important. Stage 2, typically the masses are between 2 and 5 centimeters. It's about 70% survival rate. Stage 3, 39%. Stage 4 is 17% in 5-year survival. So that slide, I just try to emphasize that screening is important, which goes on to my next topic here. And it's sort of the workup here of breast cancer, and it's mammograms. So they're not always the most popular test, but they are really the best screening tool we have for breast cancer. And some of the reasons for that are because they're so easy to do as far as comparing from one year to the next. And that's a great way where you can find if there's a difference between last year's mammogram and this year's mammogram, and you're catching something tiny and you're finding it in that. They're low cost, and so they're those are probably the two kind of the easiest or best ways to explain why they have persisted. I know there's lots of new studies where they're trying to track women that come in for a screening mammogram, and they'll get a blood test at the time of their mammogram, and they're looking for a marker that's in our blood that would show breast cancer. But as of yet, there's no good marker in blood like you can, like they use for ovarian cancer and some of the other cancers. We don't have one for breast cancer. So disadvantages: patient discomfort from the compression, the ionizing radiation, and sometimes they're difficult to interpret, and so additional testing is needed, which can be frustrating when you just want to know the answer. Something to know about the ionizing radiation is that the amount of radiation you get to your breast and from a mammogram, and I just kind of point that out, that it's the ionizing radiation is on your breast, and it's not fractionized to other parts of your body. It is about equivalent to living in Denver for a year. So when you live up closer to the sun, you get that same amount of radiation. And so it's sort of something to know about. There's people that live their whole lives in Denver. And I think people get worried about the ionizing radiation. So I kind of give that as a little example. So that they can understand that they're safe. Any questions coming in or anything like that? Am I boring everybody? You guys tagged along, okay? All right. Nope. So one thing I want to point out is tomosynthesis. It's a 3D mammography, and it's part of regular screening mammograms at MetroHealth, and I know at UH as well. And so 3D, so when you go in to get your regular mammogram, the tomosynthesis is the 3D part of the mammogram where these radiologists can look at several slices right through your breast, and they can find new areas of architectural distortion or anything, and they're gonna, it's helping to catch the tiniest little changes. The other thing is this slide says little compression is required. And what that means, it doesn't mean that the compression is less, but what it means is that the amount of time that they need for the compression when you're doing like when you have tomosynthesis is less. And so it's a shorter amount of time that we do the compression on these mammograms, and highly sensitive. This is really, really good method in screening mammograms. The technology is really moving forward. And then breast MRIs is, they're highly sensitive, very, very sensitive, the most sensitive breast imaging tool we have. And these are reserved typically because of insurance, what insurance companies will pay for. You have to have a lifetime risk of greater than 20%. And there are several ways that can be calculated, or you have the history of the, the chest wall radiation from maybe, lymphoma at an early age. Let's see here, the atypical pathologies I was talking about that are found in biopsy and surgery. So those are kind of the most common ways that you'll end up getting one of these MRIs. So they're because they're very expensive, otherwise the insurance companies do not pay for them. Also, you can have a diagnosis of breast cancer and have dense breast tissue, and a lot of times they'll order an MRI as one more thing to do before surgery to make sure that we're not missing anything in your breast before you go in for surgery.
And
yeah.
First of all, thanks for clarifying the difference between the tomosynthesis, the 3D mammography, because that was something even enlightening for myself. But for example, if I had a young lady who her mom was diagnosed with breast cancer at the age of 32, would she then a candidate to also have an MRI in addition to a mammogram?
It's possible. So we would run this model. There's a lifetime risk calculator model. It's called the TC model or Tyrer-Cuzick model, and it looks at family history. It puts all this information together, like the first day of her first period, how old she was for her first period, her first pregnancy, did she breastfeed, how many children did she have, and then all the family history. And then it runs this calculation. She would be somebody who should definitely start getting screening mammograms at 30. Her mom was 39. And there's a high chance that MRIs may also be part of that. We just have to run the little TC model on her to find out for sure. It's really this huge hassle, unfortunately, insurance companies, because they're so expensive. You have to get that. You have to be at that 20%, but I bet she would probably meet the criteria. Good question. ABUS, automated breast ultrasound. This is another way of screening. So it's for women that have dense breast tissue seen on a mammogram. And this is a large, if you can see in this picture, it's a really large panel breast ultrasound. Instead of the little handheld thing, it's a wide panel, and they just roll it over your breast tissue. And it's another way of really, if you've got dense breast tissue, these radiologists have a hard time seeing in through your breast tissue. And the ABUS is a really nice extra way of screening, especially if you know a woman who's got sort of a high risk background as well. And they find all kinds of stuff. So these are really helpful. So we talked about this impact of screening, detection of cancer at early stage. Patients have more treatment options available to them, better chance of good long-term survival for breast cancer. And that is what we want. So I think we talked about this a little bit, but so on a mammogram, just because you have an abnormal mammogram or you have a category 0 mammogram, it doesn't mean that there is breast cancer in there. Or if you have cysts in your breast, that you're going to be at higher risk for breast cancer. So there's all kinds of benign breast finding, like cysts and fibroadenomas, non-proliferative lesions, which would be sort of like a papillomas and things like that kind of hang out sometimes in women's ducts. Fat necrosis, intramammary lymph nodes are commonly found, lipomas, and and then calcifications also. So calcifications show up mostly on mammograms, and I think I'm going to show you a few pictures of that. A few pictures of like what these things kind of look like, and go over this quickly too. So a lot of times you guys will get a letter in the mail saying your mammogram, you know, was IRADS 1 or a negative mammogram, meaning it was normal, there was no findings, or there could have been a benign finding like a cyst or a fibroadenoma. IRADS 3 mammograms are probably benign. We'll kind of dig into that a little bit too. BI-RADS 4, suspicious abnormality, and that means you need a biopsy. And BI-RADS 5 are highly suggestive of malignancy. They're very suspicious appearing to the point where we almost don't need to do the biopsy. We know that this is highly likely to be positive for breast cancer. So the BI-RADS 1 and 2 account for about 87 to 93% of all our mammograms, and so that means like something normal. It was normal. There was no changes, or a benign finding like calcification, something like that was seen on the mammogram. And so the recommendations to come back in a year for a mammogram. I have this nice little picture. These breasts right here are nice. They're just completely almost fatty breasts, and there's no findings in this. You can see the chest wall in the center there, and the little nipples, out at the ends, and that's the profile picture on that. The lines in there is just the vasculature that's kind of going through your breast tissue. And so something showed up on a breast like this, you'd be able to see it from a mile away, because otherwise it's just kind of a fatty breast. BI-RADS 2, you can see these kind of white groupings here up closer towards the nipple, and those are calcifications that are benign and not concerning, and they're very demarcated. They call them like milk of calcium calcifications, and so from the mammogram, a radiologist can determine that those are non-concerning. And they'll say come back in a year. BI-RADS 3, these mammograms, you'll get a letter in the mail that says your mammogram was probably benign. And this is when people kind of start to get bothered by the letter. Probably benign, what does that mean? And you hate to get something like that. Are they hedging? Like what's going on? And I could tell you, at least at MetroHealth, they don't hedge, like if they think they need a biopsy something, they're going to have you come in and get the biopsy. A BI-RADS 3 is just something that they don't want to wait a full year for. They want to see it another year. They want to see it in 6 months or in 3 months, just to make sure it hasn't grown or changed. It looks benign at the time, and they're being very careful with you to make sure it hasn't grown or changed. And so a lot of times, the first time they'll see a cyst on a mammogram and ultrasound, they'll say, probably benign, but let's have her come back in 6 months, look at it, establish that it's okay, and then move on. And they do that also a lot with calcification seen on mammograms. So you're always coming back in a shorter distance to look at it again, instead of waiting a full year. These aren't that great of pictures, but you can see some of these on the mammogram I think it would be your guys' right, where you can see a biopsy clip up in the top corner, and these little calcifications that are kind of grouped together. That's sort of an example of, they look like benign calcifications, but they want to be able to see, want them to come back and take a look at them again. BI-RADS 0, those are That's when you come in for a screening mammogram, and the radiologist wants you to come back and get an ultrasound because they can't tell what's going on. They can see that there's a change on your mammogram, and so the next step is to come in for an ultrasound or a diagnostic mammogram and take a few closer pictures before they can decide, make a determination about what needs to be done next. And that accounts for about 68% of the screening mammograms. So this one with that big white arrow, that's sort of an example where they can't figure out what's going on. Maybe that was a change in their mammogram from the prior year. And so they typically have people come in and get an ultrasound. IRADS 4, this is usually, you'll come in for a mammogram, you'll come back for an ultrasound, and when they recommend a biopsy, they would mark it as something that looks suspicious on the mammogram. And usually those look like, poorly defined masses or some kind of asymmetry. And here's some pictures. So when the calcifications are grouped and sort of spread out, like you can see on these two pictures on the left and the right, and then also this more spiculated mass that's real white on the other side there. BIRADS 5, like I was talking about, those are those highly suggestive mammograms that look like that's likely cancer, and we need you to get in for a mammogram. And as you can see, this mass is what we call like a spiculated mass, where it's kind of got like legs on it, sort of spread out and near the chest wall, which is also concerning, sort of this white background here. So so that kind of gives you, and then this is another little chart that shows you what I just talked about, and for each type of mammogram and what you could expect, what the follow-up would be. So I don't need to dig into that too much more. Diagnosis of breast cancer. So once you've got that abnormality and you've gone on to have a biopsy, an ultrasound guided biopsy, and you get the diagnosis that that the biopsy came back abnormal. Sometimes extra testing is done. I think we had talked about the need for a breast MRI in younger women that have dense breast tissue and a new diagnosis. Breast MRIs are used as just one more way to make sure we're not missing anything within the breast tissue. Chest x-rays, CT scans, blood tests, those are also all used prior to maybe first treatment. So this is kind of a picture of some of the like way breast cancer stage, and we talked about this a little bit too. Get caught up on my slides here. Yeah. So stage 0 breast cancer is something like ductal carcinoma in situ, or they call it DCIS, and it's a pre-invasive form of breast cancer and has not left the duct of origin. And so there are no cancer cells outside of the lining of the duct of origin. And so they call it a pre-invasive breast cancer. There's no concern that it is spread to your lymph nodes and that is localized to this, area where the abnormality is seen. Can you guys hear my dog?
Oh,
I need to stop my dog. He's whining. Okay, hold on. I got to run outside. Hold on really quickly. Hold on. I'm so sorry.
I was wondering where the howling was coming from.
Oh, I thought that was a kid or her daughter or something.
Oh, that is cute. Oh, goodness.
Hey, you go walk with no clothes on.
So for what you do, Lavada, so whenever there's someone that you suspect that has breast cancer, you refer them over to Ann?
So the first thing I do automatically is when they come in for their annual, I usually just send them for mammogram.
Okay.
Or if they're coming in and they're younger, depending on who they are, sometimes if they're having like pain or something like that, they're under 40, I will send them for ultrasound and give them a breast clinic referral. If they're older than that, 40 or older, I'll send them for a mammogram. If they're coming in and they look like they got an abscess or something like that, I'm just gift wrapping that and giving them a a referral to the breast clinic for Anna.
Gift wrapping it for me. Thank you so much.
Nice.
She was so nice. She puts a little bow on top. And maybe like a little heads up message like, hey.
Her heads up message like, hey, you have this one coming, copy her on the chart so she'll.
Okay, so I was talking about pre-invasive cancers like DCIS, ductal carcinoma in situ, and how so surgically they typically don't check the lymph nodes because there's a really low concern that the breast cancer has gone into a lymph node when we know it's pre-invasive. So stage 1 breast cancer is measured by biomarkers and also size of the cancer and lymph node involvement. In fact, all of these at this point, like this picture can show you, the size, and it's showing you some lymph nodes that are involved as you go up in the staging, or, and then when you go into stage 4, where it's showing you that there's, organs that are involved. But it's a little more in depth than that, and it also entails the biomarkers that are associated with the breast cancer, like the estrogen receptor, progesterone receptor, and HER2. So that kind of all helps guide the treatment. Just talking about diagnosis and kind of making informed and making the best decisions, and really when you come in to meet with your surgeon or the medical oncologist on the first visit, and they go over their treatment recommendations, and they begin to kind of sort of see there's lots of individual kind of decisions that you can make when you have a earlier stage breast cancer. And so they'll kind of walk you through all of that and help you make the most informed decisions. And so I've kind of touched on this, I think, throughout, but so the treatments for breast cancer is surgery, which is typically the first line of therapy in most of the earlier stage breast cancers. And then after surgery, there's the chemotherapy or anti-hormone therapy, and then also for some women also radiation therapy. And it gets really individualized as far as what recommendations each person gets. And that's actually a really cool part about this whole treatment, is that no one's story is the same. And a lot of women will come in and be like, my neighbor had a mastectomy and she had chemotherapy and she needed radiation therapy. How come I don't need any of that? And it has a lot to do with the differences in maybe the biomarkers or the size of the cancer, and or if they're spread into lymph nodes. And so I think that's where the research is really like kicking in with breast cancer treatment. So, and this is basically what I was saying, kind of decisions about treatment made with the involvement of the patient, the surgeon, the medical oncologist, and the radiation oncologist in it. And it's a team that kind of comes around you and gets you through this, as well as friends and family and nurses and all of that. So it's here's a picture of sort of like real old school mastectomy. And this is where we've come from. This is 70s, 80s. This is, we would take the chest wall. You can see that kind of like divot at the top of that picture where they took out the muscle, and the morbidity from a surgery like that is rough. You're going to get, lymphedema, and they just scraped everything right off the bone there. Compared to what we're doing these days. So let's see here. Breast conservation therapy is, or they call it BCT, or breast conservation therapy is lumpectomy or partial mastectomy. These terms are used kind of interchangeably, and radiation therapy is almost always typically recommended and so they lump it all together and say breast conservation therapy. It's recommended for women that have lumpectomies or partial mastectomies to treat the whole breast. And they call it breast conservation. So here you can see in this picture, we've got, in the first picture, sort of like the little purple dots show where the incisions would be, and then the next picture in the middle shows what they've taken out, which is the little tumor, and then also the, the little sentinel lymph node biopsy. So they just take out the first 1 or 2 lymph nodes associated with your, that your breast empties into. And then you see the scars. Sentinel lymph node biopsy is done for women that have invasive cancer. So that's anyone who's got invasive ductal carcinoma or invasive lobular carcinoma, but not the women that have ductal carcinoma in situ, which is that pre-invasive type cancer. And it's a way, instead of taking out all the lymph nodes in your armpit, it's a biopsy of the first 1 or 2 lymph nodes that drain your breast tissue. And the lymph nodes that drain your breast tissue are in your axilla or your armpit. And so prior to surgery, they do a little injection around your nipple with the special dye that helps them find the first 1 or 2 lymph nodes that drain your breast. So during your surgery, they just take out 1 or 2 lymph nodes and look to see if cancer is in those. If it's in those, then it may be in other lymph nodes in your armpit. But if it is not in those, then it's pretty safe to say that there's no cancer in the rest of the lymph nodes in your armpit. And they like to have a clean margin around the tumor. So they'll take out the breast cancer tumor, and then they want to have tissue around that does not have cancer in there, or they'll have to, go back in and take out additional tissue until we know that there's a clean margin around the outer aspects of your tumor, your cancer tumor. So in most cases, this is what we're recommending for women that have been diagnosed with breast cancer. A lot of women are kind of leaning towards this breast conservation therapy, which is, like I said, like partial mastectomy or lumpectomy with a sentinel lymph node biopsy, and then radiation therapy to the whole breast. And here's a picture of a more like updated mastectomy where they left the chest wall. And we do mastectomies and sentinel lymph node biopsies, pretty frequently, so that we're not taking out all of those lymph nodes unless absolutely necessary. And with reconstruction, can come out really nice and almost look about the same. And there's all different kinds of reconstruction that they're doing now, where they're using, abdominal fat and putting it up in your breast tissue, or some silicone or implants, and then a lift on the other side, just to kind of make the cosmetic outcomes are important, and so there's a lot of work being done just to make that turn out well. So you can kind of see the stages here from what we've come from to now with as far as mastectomies. And if you see that far one with the kind of you can see that abdominal incision, and that's a picture of someone who's had their belly fat taken and replaced up into their breast tissue. So that's sort of the evolution of surgery for breast cancer.
Anna, if they ever need to borrow belly fat from anywhere,
Yeah, if we can find some volunteers. Yeah, okay. Yeah, so if you have a mastectomy, it's not typically recommended that you have radiation therapy, because all of your breast tissue has been removed. And so radiation therapy is really kind of reserved more for this breast conservation therapy or women that have had the partial mastectomies. The only time that a woman ends up having radiation therapy with and has had a mastectomy is if there's been some kind of chest wall involvement, so there's cancer found on the border of that chest wall, or if there were multiple positive lymph nodes in their axilla. Otherwise, most of the time with the mastectomy, radiation therapy is not recommended or not needed. Yeah, shorter hospital stays. I know at MetroHealth, you just stay one night in the hospital, even if you have reconstruction, which is kind of nice. And better recovery from surgeries, and less complications and lower morbidity, which really means like those side effects like lymphedema and some of that, and some of the nerve damage and pain that you could have if you could imagine them kind of removing all of that chest wall and some of the muscle tissue in between your breast and your ribs. So chemotherapy. So the goal of chemotherapy is to treat cancer cells that may be in the bloodstream and to reduce the chances of cancer from coming back. And not all women and men diagnosed with chemotherapy need breast cancer need chemotherapy. So it depends a little bit on some of the biomarkers that I was talking about. There's a certain set, like you might hear someone say, I was triple negative. I had triple negative breast cancer, and that's pretty much a guarantee that you're going to need chemotherapy. HER2 positive breast cancers also receive like an intravenous treatment as well. But there's this test, it's called the Oncotype test, and that is what we use to help us determine in a lot of borderline cases which women need chemotherapy. And it's used on someone who's estrogen receptor positive and has no lymph node involvement with their breast cancer, which is a pretty big majority of breast cancer cases. It looks at the actual gene makeup of the cancer cells in your breast. So those breast cancer cells, not your own personal gene makeup, but the cancer cells gene makeup. And it looks to see how high risk it is for recurrence. And they've got it down to like a specific number for who needs chemotherapy, depending on how high risk your cancer is for recurrence. And so it's really cool. And there's targeted treatments. So it's growing a lot, and lots more, I think, science and improvements to come. Radiation therapy, this is one of my last couple of slides here. I'm rounding the bend. So radiation therapy, and I'm showing this with brain because I wanted to bring up a point, and this was kind of the best picture I could find for it. But radiation therapy, like I was saying, is given to women that have had the breast conserving surgery. So those are like a lumpectomy or a partial mastectomy. Then radiation is always recommended for these women as long as they're under 70. So, and it's to decrease the risk for local recurrence. So you get radiation therapy to reduce your risk of breast cancer recurrence in your breast. And it's focused and targeted to your breast. And on this last kind of comment there is that it's there's a lot of advancements in this field, and so that there's less toxicity, because with radiation therapy you can get really bad skin burns, and people worry about injury to your heart or to your lungs, especially on the left side. And if you see these pictures here, the top one, you can see that beam, it goes all the way through the head, and that's sort of some of the more traditional type of radiation therapy. And then if you look on the bottom one, you see that more, the beam that stops, and they can actually target the beam and how deep they want the radiation therapy to go. So they can designate the depth with the radiation therapy, and that's proton therapy, which is sort of a move in the treatment of radiation for breast cancer. And so we're moving in that direction. I think that's pretty exciting.
Yeah. Cutting edge.
Yes. So that pretty much wraps it up. What do you guys think? You got any questions? There's so much more nitty gritty we could get into because it gets so individualized, and I just wasn't sure how much to break it down.
I think this high-level overview is excellent. It brought back a lot of memories about when I went through treatment. I know when just the first diagnosis or the first indicator that, hey, you have cancer, it was just a whirlwind, multiple mammograms, the MRIs, the ultrasounds, the CAT scans, the multiple biopsies. It's very intense. But for you, how long do you stick around after the diagnosis is made?
Well, I see people in follow-up for 5 years after diagnosis, typically. And so we try to make it so it's once a year that we'll see them at the time of their imaging, as you kind of get further out. And I tell a lot of people that because it's a really good point that it's so overwhelming at first with diagnosis. And they're like, I have a life. Like, I can't come in here every day and get my genetic testing, get my MRI, then come back and get a CT and a bone scan. And wait a second, now you want me to get another ultrasound and another biopsy? Like, it can definitely get that way prior to your first treatment, and it can be so overwhelming. And so we try to let people know that we want to make sure we're fully informed before we begin any kind of treatment, and then we try to stay out of there, try to keep them out of visits to the doctor after that. But yeah, so I follow people about 5 years after, between me and my collaborating physician, Dr. Joseph. She's a surgical oncologist and does a lot of our breast cancer surgeries at MetroHealth. And between her and I, we'll see a lot of women through follow-up for the first 5 years.
We got a comment on Facebook. Someone said this is very good information. So thank you so much for sharing this.
Yeah.
At the beginning, you spoke about, making sure that you make the best decision for you. So I know when I first was diagnosed and I had to figure out whether I was going to do a lumpectomy, mastectomy, double mastectomy. Oh, geez. It's like, how do you really know what's the best decision, But I can say that, you and a lot of providers like you provide a lot of information to help you make the right choice. So any of our listeners, just be transparent with, your doctor or your nurse practitioner, telling them about your lifestyle, because this change that you make or this choice that you make, it becomes you, and you have to make the best one for you. Yeah.
That's such a good point. And also too, one thing that I see a lot after women have reconstruction, it doesn't always look as beautiful as those pictures. And then they feel guilty that they don't like the cosmetic outlook, the way it looks cosmetically, but at the same time, they are a breast cancer survivor. And sometimes it breaks my heart that feeling of guilt that they'll have, I feel so bad, I don't like the way this looks, but I feel like I should be happy because I made it through breast cancer. And it's okay, and I think it's okay to not be happy with the way it looks and to go back and try to get things fixed or balanced. I mean, I see that a lot. I almost, one woman was asking if she could have grief counseling, because she was grieving the loss of her breast. She said, this was my best feature. My breasts were my best feature. And she's like, I didn't actually really realize that until it was gone, that I was so proud of my breasts. I liked it better than my smile, my eyes, and it's such a, it's the way you look at yourself in the mirror every day. And so it's a really important decision and a hard one. It's hard. It can be hard to make.
Definitely. You know, I shared with you earlier, you know, I was never a girly girl. And I didn't realize how much of a woman I was until I lost one of my breasts. I just didn't feel right. So,
Yeah.
you know, some people may think it's vanity. No, this is you. It's tough. It's tough. It's very tough. But technology, medicine has advanced, you know, and I appreciate you sharing the pictures from the 1970s because it does not look anything like that now, you know. Yeah, if I would have saw that picture, I probably would have just, hey, I'll take my chances with breast cancer. But and to speak to that, a lot of the clients that we serve, we all do research online and we look at all these pictures and say, oh no, I'm not going to do this. I'm going to look like this. But we try to encourage everyone. You know, I've sent people snapshots of my boobs a lot. It doesn't come out like that anymore. You know, there's hope.
Yeah. It's so true. Or like they'll say like my grandma had a mastectomy, and they'll remember taking care of their grandma after that, and they will absolutely, you know, be filled with fear and so there has been so much advancement in that and yeah, and so there's that struggle. Like, it's real. Yeah.
But technology has come a long way. We even have prosthetics now. So hey, get tattooing. Still bring that feminine womanhood back. And it was one question I wanted to ask you, and I'm trying to I was writing notes while you were talking, and I can't find it. Lavada, do you have any questions?
No, I'm good, but I guess I would just make a comment to go along with what along the lines with what you guys were saying. We never know. Everything is individualized. What defines us as a woman or what we feel makes us a woman is different for each of us. I'm in the office every day with women and you know, I'm doing a lot of education and family planning with them and birth control management. And some of them, they just have to have a menstrual cycle to feel like they're a woman. And they'll say, well, I don't want birth control that's going to make me not have a monthly cycle because that's how they feel like they're a woman to have that monthly cycle. Power to them. I don't want that for me. I'd rather forego that. But you just have to realize what defines womanhood for each woman. So whether it's their breasts or whether it's a monthly cycle or whatever it may be for each individual woman, you have to appreciate that for that person and try to preserve that because we never know when we don't have that body image disturbance or how that can affect them mentally and make them feel less than.
That's absolutely right. You don't know, you know, what makes you feel like a woman, and it's really vital. You know, it's important to understand that and speak it. You know, and speak up about it. And
Right.
Oftentimes out here, I think I speak to multiple women through my sister's keeper, and the way they would describe themselves as an alien, you know, to that, you know, you're walking around with one boob or maybe one or a lump in your chest that wasn't there before. You lost your hair, you lost your eyebrows, and you just lose a piece of yourself on the inside that is gone. So it's a battle. It is tough. It's tough. Yeah, but we try to help as many as we can because you can't do it by yourself. And we just, you know, all the work that you do in. And I finally found the question that I have two actually. So I was diagnosed with breast cancer at the age of 32. So, you know, my girls they'll be 15 on the 10th. So their directive is when you're 22, make sure you start screening for mammograms. Make sure you know your boobs now and track the changes. So one day, my oldest twin, just by a minute,
I like that.
She had a lump under her arm, and she was scared because she thought it was. But it was actually, we changed her deodorant, and so I knew it was that. But is there a telltale signal? Because I think we all do this, especially our deodorants. How do you know hey, this is something I need to go to the doctor and be screened for, or this is nothing. So is there a kind of balance to know when to go to see, get a check?
Yeah, I like that question. Okay. So superficial. Do you know what that means? Like right up in the skin and that dermal layer, that's something, especially if you're talking about in your armpit or your axilla and you feel a lump or a mass in your armpit. If it's superficial and really like in the layers of your skin, you can be less concerned about that. You can also be less concerned about like a tender lump, something that's tender and um, um, or something that you notice around your menstrual cycle and then it fades away um, as your menstrual cycle passes, or you notice it as a kind of a cyclic thing, less concerning. If you have a history of, you know, sebaceous cysts or things like that forming, you know, that's another, you know, it's a really common finding. Lipomas or sebaceous cysts or abscesses are pretty common findings in your armpit, as well as like little fibroadenomas and also accessory breast tissue. Even in, you know, it's not like you've got this huge fatty lump in your breast, but you can sometimes have that tenderness or pain in your breast, and it can be just sort of some accessory tissue. But most of those things are associated with a tenderness that's either cyclic or a tenderness that improves with warm compresses. Something that seems to persist or is non-tender, those would be the things you would want to come in for. Is that helpful?
Yeah. So when Anna was saying like the cysts, or when you constantly get those cysts or those sebaceous things, so she's kind of referring to what we commonly call or refer to as boils under our arms, like when grandma or auntie have those boils. Then we try to do those warm compress like 3 to 4 times a day to see if they will come to a head, if you will. And if they don't, or like Anna said, they persist, then we definitely want to follow up for those and make sure that that's what it was.
Good response. Thank you both. Another question I have for you: what does screening look like in the new age of COVID?
You know, so it looks like masks and temperature checks and not coming in if you're sick, and postponing, you know. We, for about 2 weeks, we completely shut down, and we weren't doing screening mammograms. We were only doing mammograms or ultrasounds on people that actually had palpable concern. So there was kind of a quiet period there for about 2 weeks, but otherwise we kicked right back up, and it's just checking at the door and wearing your mask. And when you sit in the little gowned waiting area, everybody has to sit 6 feet apart. Otherwise, we're trying to keep up with all the screening, because I mean, what a terrible outcome to like, you know, just another problem with COVID, you know, is to be missing people that need screenings. And I'm actually quite concerned about that, you know. So come in and get your screening mammogram, wear your mask and come in. It's so important. It's so important. Don't be scared. Come in. So
we know the mobile mammogram unit. Are you a part of that team?
Yeah. Yep. So we'll come to you.
And so on the clinic side, because again, I'm preventative care in the hospital, we're in the clinic, outpatient clinic. So we're still accepting patients for their annual well woman exams. So still make your appointments, and then we get you over for your screening exams. Again, we ask that if you are having symptoms, or you are sick or believe that you do have COVID or tested positive, do not come or wait your 14-day period and have been in isolation. But other than that, please come to your appointments, and I will definitely write your order to set up your appointment for your screening mammogram. Or if you need to go to the breast clinic, I will give you your referral to see Anna. And we'll go from there, and depending upon your results, you'll go through the process thereafter. But we definitely do emphasize that you still need to come and have your annual checkup so that we could definitely take care of that and do preventative medicine, because again, screening does, early detection does save lives.
Well
It sounds good.
said. Well said.
Cool. Well, Anna, how do we reach you? So, any of our listeners, anyone who's watching us, we've had a suspicious lump in our breast. How can we find you? How do we reach out and make an appointment with you?
Well, there's lots of different ways. Probably the easiest way is to just get online and you go to the MetroHealth Breast Center, and there's just one number there, and you tell them you want to come in and see Anna, the nurse practitioner. You can just say Anna; they'll know who you're talking about. But Anna Persis is my first and last name, and I'll be happy to help you out with any problems. So.
Excellent, excellent. We'll track you down.
Yeah. Do you want me to rattle off the phone number? Will that be
Yes.
okay? It's 216-957-2778 is the phone number to call. So and ask for an appointment with Anna.
Right,
Thank
excellent.
you. Yeah.
This has been an honor and a treat, and we are looking forward to having you back along with Miss Lavada Tilly and talking about preventative. We're going to talk about prevention and ways to avoid diagnosis, correct?
Yeah. Yes. Lifestyle changes. I think Lavada and I would have a lot of fun doing that together, kind of working on some preventative breast cancer strategies and some really easy things and some harder things, but just working together on that and kind of giving you further education. Would love that.
Yes, that'd be awesome.
Yes. Just let me know when you're free. We'll love to have you back. This has been awesome.
Yes, been a joy. I love working with Anna and so her patients.
Well, I think that the whole mission for My Sister's Keeper is awesome, and I just know so many women that would benefit from you guys, and I'm really excited to keep spreading the word about My Sister's Keeper and get people to donate to your cause, because I think you give money to people that are really in need, and taking away a little extra elements of stress is good for their health and good for their survival, and that is such a big deal. That's such a beautiful thing. So you guys rock.
You have me tearing up over here.
Oh, I know. I can see the faces of all these women I know that would just, they need a break, and it's so awesome that you guys are out there for that.
We always hear anything we can do to help to alleviate that stress, because with that diagnosis, it seems like the world wakes up around you and just want to overload you with everything. Feel stress, kids, anything you can think of, it just all comes just pouring on you. And if we can do anything to help alleviate some of that weight, we'll do it. Yes. All right. So for any of you interested in learning more about My Sister's Keeper, you can reach us on our website, which is www.mysisterskeeper-cle.org, or give us a call at 216-333-1819. You can also join us on Facebook, My Sister's Keeper Cleveland, and we're also on Instagram. We hope you have a wonderful evening, and thank you, Anna, so much. We'll be in touch. You are a new member of our family, so thank you for joining the My Sister's Keeper Cleveland's clan. Lavada, thank you as always. Do you have any closing remarks before we tune off?
Just thank everybody for joining. It's a pleasure to have you. Pleasure to have Anna anytime. And thank you, Mary, for everything that you do.
Hey, this is all you, dear. Thank you. Have a good night, everyone.
Thank you.
I stopped the recording. Okay, I stopped the Facebook Live. Everything is good. Thank you. I think I stopped.
Oh,
Okay.